Good morning, everybody. And Mauritius is not superstitious, but I can tell you his heart skipped a beat when he heard about that defibrillator that is here. It is a great pleasure to be here, and I don't have a lot of time, so I have to get at it, and I'm going to right now with a story. And you can tell me if you've had a story like this. The young'uns in the audience, maybe you haven't, but you will, I guarantee it. This is the story of a 68-year-old woman with end-stage multiple sclerosis who was brought to the A&E, and she was at a stage when she could no longer speak for herself, she couldn't feed herself, she couldn't ambulate, and her family asked that she be admitted to hospital. Like many families, they had cared for her lovingly at home, but they had reached the point where they were uncertain of the future. Was she moving into a pre-terminal and even a terminal phase of her life? Was she, if they cared for her at home, would they do something wrong? And like a lot of families, they brought her to the A&E, not knowing what to do, but with a firm insistence that she be admitted to hospital, perhaps for a time out for the family to gather their thoughts cognitively and emotionally, perhaps because they wanted her in a long-term care facility, and that's what her family wanted. And the emergency physician who saw her was not a fool, not the kind of person who would refuse requests, not a gunslinger. No, I will not do what you want. He made the referral, but it took a long time for her to be seen because she wasn't dehydrated or septic or febrile. She didn't require intensive care. And so the internal medicine team triaged her at a very low level of acuity, and it took hours for her to be seen, and the family grew impatient. They kept asking the emergency physician every time he walked by the cubicle for updates, and after the 17th time, he snapped at them. He didn't yell at them, he simply said, "I did what you asked," and walked away. Well, the woman was admitted to hospital, and she did die several weeks later, and about 6 months after that, the emergency physician received a long, beautifully handwritten letter from the husband inviting him to a meeting with the family so that he could learn all the things about this woman he did not know, and perhaps didn't care to know about during her lifetime when he was looking after her, when she was his patient, and also to see, quite pointedly, if there lurked underneath that brusqueness any scintilla of kindness. And that was me. I was the emergency physician, and that's really what set me on this journey of discovery, and I'm going to share some of that with you right now. But first, let's start with some definitions. Sympathy, and there are, I always get this mixed up, entomologists and etymologists. The difference bugs me. I know that words matter, but unfortunately some of these definitional terms have devolved, and sympathy should mean feeling what the other person feels, but it has devolved into a superficial gesture of concern, sorry for your loss, and there's something important about that. When you are extending a gesture of sympathy, there's a good chance that you are preoccupied with your own distress. I never know what to say at a time like this. I'm afraid of putting my foot in my mouth. I'm afraid of being awkward. And so we come up with stock phrases like sorry for your loss. That's what sympathy is. Empathy has 3 components. It actually has 5 components, but I don't want to make it too complicated at this hour of the morning. The most important component of empathy is the capacity to imagine what it's like to be someone else and to have that not govern your actions, but inform your actions. So the best way for me, very simple technique, to empathize with you is to be with you. Okay? What's the point? What's he talking about right now? I'm tired, I have to go to the bathroom, I just got here, I'm cranky. What's he going to talk about? And so I'm empathizing with you by being in the audience with you. So, cognitive empathy. There is something called affective or emotional empathy, And you may have heard of a book called Against Empathy by Paul Bloom. It's a wonderful book. He sets up a straw man in which he knocks down empathy as something that's valuable in everyday interactions with people, because if you feel somebody's pain, you might be motivated to end the pain when you need to maintain your objectivity. And when it comes to health professionals, we don't want health professionals to have abundant affective empathy. We want them to have cognitive empathy. On the other hand, you will not be able to help yourself. You're going to see patients who remind you of your mother, your father, your partner, your children. They will remind you of your own personal history, your own disappointments, and you just need to be prepared for those, to deal with them, and sometimes even to step out and have somebody else care for the patient during that period of time. Compassion, sometimes referred to as compassionate empathy, affective concern, that's the get up and go that makes me want to run to the resuscitation room instead of away from the resuscitation room. And we want health professionals to have that in abundance. Now, kindness, why did I call my book The Power of Kindness? I looked at the bookshelves and I saw 75 or 100 titles about empathy and maybe 2 about kindness. And as a wise person once told me, Brian, if you can't be the best, be different. And so I wrote my book called The Power of Kindness, but what I found, it has a banal definition: friendly, generous, considerate, compassionate. Compassionate is not banal, of course. Where it gets interesting is in the etymology of kindness. It's derived from the Old English word kind, which is the same root as kind, as kindness, but also has the derivation of my kind versus your kind. And I'm going to get into us and them in just a moment, but the important thing about that is that in a moment when you extend kindness to somebody else, you see that person as you, as somebody who could be a member of your tribe, your group, and you want to help them. The good news is we are, on the one hand, hardwired to be empathic. And many studies have shown that newborns cry when their mother cries, and mums and dads bond with their children from birth, especially mothers, under the influence of oxytocin, which helps prepare the womb to give birth, helps prepare the breasts to give breast milk, and makes mom go gaga over baby. And from the first few hours of birth, mother and baby will be looking at one another. Baby can't, of course, focus on mom's face, but the baby is able to hear mom's voice, has been very used to mom's voice for months now, and over the course of the next few months will be beginning this pas de deux, where they will be mimicking one another's facial expressions, and then vocalizations, and then words, and then songs. And this is the beginning of attachment between parents and children, and it is a cornerstone of how we bond to other people. In fact, there are studies that show that when clients and therapists are clicking with one another, when their therapy is going very well, they tend to mimic one another's facial expressions and verbalizations. And if you go to a bar or a coffee shop, look for any dyad, any twosome, and you'll know if they're getting along by whether they're mimicking one another's hand talk. Empathy is a cornerstone of emotional intelligence, as Daniel Goldman has said, and so it's important, but just keep in mind that empathy is not there at all times. We are complex human beings, and empathy, because of executive function, becomes a choice. And I choose whether I'm going to be kind or not, whether I have enough time, do I have competing interests, my families versus your families, my groups versus your groups. But suffice it to say that if we did not have empathy for one another, we would have killed one another a long, long time ago. So we have that. And then we have this. Within nanoseconds, the neuroscientists tell us, neuropsychologists, if we are shown a photo of somebody, we will decide, are you a member of my tribe or are you a member of the other tribe? What they call in-groups and out-groups. And if I have decided you're a member of my group, I will give you the benefit of the doubt. You're kind, you're empathic, you're industrious, you're generous, you're charitable. And if I think you're a member of the other group, you're unkind, you're stingy, you're lazy, etc. And I can't help myself. We're hardwired to do that. So what stops us from being mean to everybody? Well, we have this thing called executive function. And executive function is what tells us, oh, that can't be true. And so we override this basic instinct to divide the world into us and them, unless we're under stress. And I would say to you that the United States is one country that's under a tremendous amount of stress right now. And so it sees barbarians at the gate. It sees, I think many Americans, I'm not speaking for all of them, see their lifestyle, their economy, their housing, their stature, their standing as under threat. And when you feel as if you're under threat, then you tend to shift away from empathy towards us and them. And so I would say that in those situations, somebody like a Donald Trump is not the person who's creating this, but he's exploiting it. And the answer to how to deal with that issue, how to cool down the temperature of us and them in the United States and other countries that are like it at this present time would be addressing the root causes of the stress. So making sure that people have a purpose, education, we're moving forward towards a goal. We're going to create a new and better world. And the more jobs there are, the more security there is, the less that tendency for us and them is there. Now, what's really interesting is that when you start to look at the culture of modern medicine, and I've been doing that for a long time from my radio show and from my books, we have a lot of us and them in healthcare, in medical culture, paramedics versus emergency nurses and physicians. You again, when we're under stress. Is there no other accident and emergency that's open right now? Emergency physicians versus internists. They never come when we ask them. And the internists are saying, they refer everything, and they've put everybody on ceftriaxone, and they've done a CT scan of everybody's head, and another troponitis, another troponin consult. Cardiology versus general internal medicine, on which specialty will admit the patient with heart failure. Surgeons versus anesthesiologists. There's something, when I did my book, there's a couple of copies out there called The Secret Language of Doctors. There is a surgical term called OAFAT. And I can't use the F-bomb because I'm not supposed to be potty-mouthed. I work for a public broadcaster. But so OAFAT stands for Operating Room Anesthesiologist Frack Around Time, if we can say that. And that's the perception of the surgeon when the anesthesiologist appears to be fussing with the airway and with the anesthetic equipment before the case can start. Residents versus nurses. Now there's one I could write a book about. Psychiatry versus everybody else who works in healthcare. Now we're getting more dangerous. Male versus female physicians. White physicians versus physicians from any visible minority. Patients and families versus health professionals. And I don't have the answer to why. Well, I have some hints as to why. But if you haven't thought about it, think about it for the rest of the day. Why do we have so much us and them in healthcare? Aw. Do you recognize that person? That was me. When I was 3 years old, I was 5 there, but when I was 3 years old, my mother said that I was referred to by counselors at camp as a breath of fresh air. So I went on a journey in my book to rediscover that kid and ask myself the question, am I still a kind soul? And my first stop was the brain researcher. So I went to Laval University and I spoke to that man, Professor Phil Jackson, and I had a functional MRI of my brain. And the experiment was a really interesting one. So I was a research subject in an experiment in which my functional MRI was being taken as on the ceiling of the MRI room. I was being flashed photos of people in various states of pain. And I had a joystick in my hand, and I had to position the cursor far to the left, zero distress, far to the right, maximum distress. So I had to estimate the amount of distress I thought the patient or the individual was in, because they were all wearing street clothes in the photos that I was shown. And they moved on to the next one and the next one and the next one. There were control groups. There were ones that were obviously neutral. And then they took a functional MRI of my brain. And what did they find? Very interesting. I don't know if you can read functional MRI reports. The set of images from the contrast between pain and no pain images. P equals 0.05, which I think is very important. Let's cut that for time. I have an underactive empathy center in that particular model of estimating the pain of my patients. And guess what? I'm not alone. It turns out that there is a cohort of experienced nurses, physicians, and other healthcare providers in mid-career who tend to underestimate the pain and distress that their patients feel. And they don't know the reasons. It's a phenomenon that seems to be reproducible. Some of the explanations might include that when I look at that image of that one individual, I'm comparing it to 5,000 other images in my mind. Maybe I'm remembering the time that I got burned by somebody who said they were in pain and they ended up selling the OxyContin that I provided for them. It's complicated. Or maybe I'm assuaging my imminent moral distress because we have this thing called an opioid crisis, and I know that I'm not going to give this person an opioid because if I give them an opioid, I'm going to hear it from my boss, my chief. I'm going to be, and maybe from the college, maybe from the regulators, the GMC. And so maybe if I can just underestimate their pain a little bit, then I won't feel so bad about not giving them an opioid. So it's complicated, as we are. How do you measure empathy? You measure it using a scale known as the Jefferson Scale of Physician Empathy, and this is a 20-item questionnaire. The higher your score, the higher you are judged to be empathic by others, not by you, by others. And women tend to score somewhat higher than men. Nurses tend to be more empathic than physicians, and these are all just vast generalizations. Psychiatrists and people involved in primary care tend to have significantly higher Jefferson scores than anesthesiologists, orthopedic surgeons, neurosurgeons, radiologists, cardiovascular surgeons, neurosurgeons, OBGYN, neurosurgeons, general surgeons, and neurosurgeons. Carolyn, that was for you. Where are you? There you are. The most important thing I wanted to tell you is that the highest level of empathy that you have as a medical student is when you enter medical school, and your lowest level of empathy is when you exit medical school. So what's that all about? Why is there an empathy gap in healthcare? And there are many, many reasons for that, but some of the most important ones, I would put to you that the medical culture devalues empathy in favor of smarts. If you saw the film Wonder or read the book, it's a wonderful book. If you must choose between being right and being kind, choose kind. In healthcare, are you kidding? Of course you have to be right. If you can't one-up people at rounds, then what good are you? And we tend to defer, we are not worthy to the smartest person in the room, not the kindest person in the room. And in fact, kindness may be an impediment to your advancement as a leader in healthcare. For whatever reason, little attention is paid in school. Now we have these interviews where we're looking for kind people, but we drill it out of them by the time they get out of medical school. Now let's talk about the system itself, the practice of medicine, and I certainly know this as an A&E physician. There is much time pressure, and it's not time. People ask me, can you be empathic in a minute? The answer is yes, provided you're not distracted by 9 other things at the same time. If you find yourself too hungry to concentrate, too tired, I have to pee, I just have to decompress for a moment, as I'm walking into the room to talk to a patient, I think about the 3 other things I haven't checked, including the repeat potassium, that's kind of important, or the repeat lactate after I've given the fluids. And we're constantly juggling priorities, and the more anxious you are, the more difficult it is to focus on that other person because you're so preoccupied with your own distress. Technology, computers can enhance the doctor-patient relationship until it doesn't, and there are many, many of us who have experienced having to re-enter passwords many times and having to yield to the logic of the software system instead of putting our eyeballs on the patient and focusing on what they have to say. Complexity is another factor. It used to be that I could walk into a room and ask a patient, I'm Dr. Goldman, what's going on? Now, if I haven't spent 10 or 15 minutes reading their old chart, I'm sunk, and so are they. And that's because of complexity, multiple illnesses, multiple comorbidities. They're on multiple medications, and it just makes us all more nervous and preoccupied. And then there's specialization. Specialization allows us to corner the market on knowledge, but we lose the patient in our specializations. So we have cardiologists looking after the heart, and respirologists looking after the lungs, and nephrologists looking after the kidney, and who is looking after you? Often nobody, and there are many, many sad stories of people who have fallen through the cracks. They certainly don't get a lot of empathy. Other factors that block empathy: moral distress. I've already alluded to moral distress. That's what we feel when the rules and the usual practice make us unable to do what our hearts say is the right thing to do. And don't underestimate this. You experience it all the time, and it is a risk factor for burnout. So is compassion fatigue, which is also known as secondary traumatic stress disorder, which is the gradual lessening of your ability to be present with a patient when you're talking to them, when you're giving them bad news, when you're talking about a difficult issue with them. For them, it's the one and only time they're going to hear this awful news, and for you, it's the 200th time or the 250th time. And we're able to replenish it, but sometimes circumstances make it difficult for us to replenish it. Both of those are risk factors for burnout, and it turns out that burnout, there's a scale for burnout, the Maslach Burnout Inventory, and there's the Jefferson Scale of Physician Empathy, and the higher your burnout score, the lower your empathy score. And that's very interesting when you talk to our critical care colleagues, where empathy is prized, but the higher the empathy that you have, the more you're at risk for secondary traumatic stress. So what's a healthcare provider supposed to do? It's a difficult thing to juggle. So far, I've talked about empathy. Let's talk about who doesn't have empathy. And there are 3 personality disorders that group together by a colleague from Simon Fraser University into something called the dark triad. People with a narcissistic personality disorder, psychopathic personality disorder, and Machiavellian. There's a lot of overlap between the 3, and Trump probably has a mixture of all 3. And I say that, and I have no problem with that, saying that. I know in the United States, if I gave this talk, I probably have to carry a handgun. But he does seem to lack empathy. I don't see lots of sincere gestures of empathy. So people who belong to those groups, brain researchers have shown us they actually lack the activity in the amygdala and other parts of the brain that we would expect to light up if they had empathy. But there are 2 types of psychopaths, and I want to focus on that for just a second. There's the unsuccessful psychopaths and the successful psychopaths. The difference is kind of soft. There are some brain differences between them, but the most important difference is that unsuccessful psychopaths spend most of their lives in penitentiaries, and successful psychopaths do not. They have certain features. Now, quick quiz question: who's Forrest Yo Thomas? James Bond. He is the prototype for the character that Ian Fleming created, James Bond. And these are people who have some psychopathic features, minus the prison resume. And they have something called fearless dominance. They're not afraid to try things. They're charismatic. They're charming. They do tend to have low empathy. But they don't end up in prison because they have strong executive function. I'd like to do that, but not a good idea. They have high autonomic arousal, which means that if they're exposed to pain, it acts as a deterrent to further action. And if they have supportive parents, these are all factors that keep them out of prison. But make no mistake, they live and walk among us. They are CEOs, they're politicians in high office, they're orchestra conductors, they're scientists, they're hospital executives, and they are physicians, particularly leaders. So, why? Why do they get so high up in the world? They're flamboyant, they're seen as shiny objects, they're charming to would-be donors, selectively charming, they're crafty at hiding their worst behavior from influential people, they are cruel and they're mean and vindictive to people they see as powerless. So I'm sure you know a few of them, and I know that a number of them work in healthcare. And I know that Dr. Gabrielle Horn knows all about this. She was on our show last year. You can check out at cbc.ca/whitecoat that program. She was a respected cardiologist at the Halifax Infirmary, and she was a translational researcher. She received a large grant from the Canadian Institute of Health Research to study congestive heart failure. And in 2002, her hospital privileges were varied. That means limitations were placed on her hospital privileges after refusing to add her clinical supervisor to the research team and as a co-author on the paper. She felt he had contributed nothing other than the fact that he was there, and she didn't play the game. And her hospital privileges were varied. Why? She had a sterling reputation. Well, it was because her attackers, the ones who complained about her for not listing her on the papers and on the research, alleged that she had harmed patients. And that's the nuclear option. If you say that somebody has harmed patients, then you get the attention of authorities. Now, in 2006, her privileges were restored. And at that point, Horne sued the health authority for loss of reputation and career, and she was awarded $1.4 million in damages for administrative bad faith. There was no basis for saying that she was harming patients. In 2018, the appeal reduced the award to $800,000. It was still the highest award for loss of reputation in Canada thus far. She complained to the College of Physicians and Surgeons, our version of the GMC, and the complaint was dismissed. It did not constitute conduct unbecoming a doctor, and the harassing physicians continue to thrive in practice, and they've moved to other parts of Canada. The health authority has yet to acknowledge any wrongdoing whatsoever, even after the Court of Appeal decision. Nobody's been held accountable, said Dr. Horne to the media. And Valerie Wise, who is a health lawyer, said that Horne's determination to see this case through for years was highly unusual because she risked being saddled with the court costs. Had she lost, it would have bankrupted her. And she also told us on our show that this kind of bullying that she experienced was motivated by threats to the power of those who felt threatened, their ego, and I would put to you that a number of the people who attacked her were successful psychopaths. So I went down the route of studying my own psychopathy. I went to Western University, where Derek Mitchell has done some groundbreaking research with paper and pencil tests that tracked perfectly with the functional MRI results of people who have psychopathic traits. And lately he has moved away from the psychopathic population to the normal population. And he uses an instrument that was developed at Emory University. It's called the Psychopathic Personality Inventory, which is a 154-question item questionnaire that examines psychopathic traits, cold-hearted traits in the general population. These are all normal people. But do they have a smattering of psychopathic traits? And here are my results. Well, I was at the 15th percentile for cold-heartedness, and as Derek Mitchell said to me, people who score like that are the cuddly types. I also scored at the 86th percentile for Machiavellian egocentricity and social influence. And he said, it means you're good at getting people to do what you want them to do, which made me feel ashamed of myself. I get that a lot. Guilt and shame are two different things. Guilt means I did bad. Shame means I am bad, as Dr. Brené Brown has said. And when you're guilty, you want to repair it, you want to learn all about it, you want to ask people about it, talk about it. When you're ashamed, you want it to remain quiet and silent. And as Brené Brown says, it takes secrecy, silence, and self-critical judgment to grow. Shame is associated with depression, anxiety, PTSD, and addiction. Interestingly, it is widely studied in the psychology literature. Almost nothing has been written in the medical literature now, thanks to Will Bynum and Diane Oban and some others. They're starting to shine a light on shame, proneness among health professionals, and I think it's probably more profound an issue than you might have thought. Why am I talking about shame? Because shame blocks empathy, and I was not empathetic to that family because I was a very shame-prone person. So how do you deal with shame? Well, did I tell you about a time when I was accused of being unkind? By talking about the things that you're ashamed of, if shame marinates in a bath of silence, then talking about it deprives it of the power to paralyze you. That's what Brené Brown has said, and I certainly believe it. So how have I changed in the accident and emergency? As a result of unburdening myself of that need to be secret, I'm less sensitive to criticism, I'm less defensive, I'm better at asking people for help. I've learned one of the really neat secrets of turning somebody's opinion of you around. If you think there's somebody who hates your guts, do something nice for them. Or say something nice about them. Recognize something that nobody recognizes, but it is a singular talent of them, and they won't know why, but they'll like you. They'll reevaluate you. I smile more often at work, especially with patients and families, and I look like I'm enjoying myself. Not their suffering, but that I enjoy the interactions, that I'm comfortable with them. I look relaxed when I'm with them, and they notice it. So, final thing I need to say, I'm just running out of time. Why should you be kind? You know, here's a survey by Resident Doctors of Canada. 77% of residents said they experienced some form of harassment in the past 12 months. 77% from patients, 60% from attendings, 55% from allied health professionals, 55% from fellow residents. They've experienced verbal abuse, work as punishment, loss of working privileges, and most remain silent for fear of losing their job prospects. That's the culture of medicine. Well, here's why you should be kind. Because intentional meanness, we tend to think that it's a winner and a loser. It isn't. When you're mean to somebody else, your heart rate goes up, your blood pressure goes up, your distress goes up, and you're one step closer to burnout. When you are kind to somebody, in spite of yourself, your worst instincts of us and them, your heart rate goes down, your blood pressure goes down, your well-being goes up. So how can you be more kind in the next 7 days? First of all, take care of yourself. If you can't take care of yourself, how do you take care of others? Forgive yourself. If you can't forgive yourself, how do you forgive others? Be compassionate with yourself. If you can't be compassionate with yourself, how can you be compassionate with others? And last thing I want to show you. What does that have to do with anything? It has nothing to do with nothing except to say this. This is my daughter Kaylee's favorite show right now. She did a winter term I know it's not Ireland, I know it's Northern Ireland. But the other thing that she told me again and again was how much fun it was to travel from Belfast to Dublin. So Brexit, no. That's all I can say, because all it does is it separates the world into us and them, and we all need to be us. That's all. Thank you. Bye.